So a lot of patients come into the hospital with various conditions, and one of them being pulmonary edema is a very, very serious condition that may lead to your patients actually dying. So I thought I should actually put a video together to teach on pulmonary edema and its management. I will leave this video also in the internal medicine playlist as well as the emergency medicine playlist. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at pulmonary edema. If you haven't yet subscribed to the channel, please hit the subscribe button. Hit the bell notification icon so you can be receiving such amazing notifications every time I post of such amazing content. To Zambia and beyond, grab a piece of paper and let's go. So remember that your lungs are very important for the purpose of gaseous exchange and pretty much to get oxygen into the body and to remove carbon dioxide from the body. So if there's anything that is impairing this gaseous exchange, potentially it will lead to hypoxia, it will lead to hypoxemia, it will lead to invariably tissues dying because they are producing less energy and toxins are accumulating at tissue level. So this impairment in gaseous exchange could be as a result of various things at the level of the lungs, at the level of the alveoli. Anything that is resulting in this accumulation of this extravascular fluid in the interstitium and in the alveoli, essentially in the lung parenchyma, we refer to that as pulmonary edema. And remember that it can arise as of two main important things. It could be either due to cardiogenic causes, meaning that these are problems to do with the heart. There's some sort of failure of the left ventricle. I'll talk about this in details in the next slide. And it could also be non-cardiogenic, meaning that there is a problem with the parenchyma. There is some sort of injury to the parenchyma. Those are the two main types of edema that could arise in terms of pulmonary edema, either cardiogenic or non-cardiogenic. So the causes can be divided into two main types, like I said, cardiogenic versus non-cardiogenic. Now we'll begin with cardiogenic. Now remember here you have to understand a few things. Remember that in the body there is a dual circulation. There is what is known as a systemic circulation and there is what is known as a pulmonary circulation. So blood that is coming from the head and the rest of the body is going to be draining by ways of the superior vena cava and the inferior vena cava into the right atrium. This blood is then pumped on into the right ventricle. From the right ventricle, it's pumped into the pulmonary trunk, which divides into the right and left pulmonary arteries. And essentially, this is going towards the lung for the purpose of oxygenation. Now, remember that this blood that is being oxygenated inside the lungs comes back to the lungs by way of the pulmonary veins. And these are going to be draining blood into the left atrium, from the left atrium into the left ventricle, then eventually into the into the rest of the body, the head and the body. So remember that if there is anything that is blocking this blood from coming from the lungs back to the heart, this blood is going to remain congested in the vessels of the lungs. And once this blood remains congested into the vessels of the lungs, it will lead to increases in the hydrostatic pressure. Now, let's take a step back a bit to understand what this hydrostatic pressure is and what oncotic pressure is, because this is very important as it's going to give you a basis of why pulmonary edema actually arises. If you have any fluid in a container, the molecules of that fluid are going to exert a certain pressure onto the walls of this container. This is what we refer to as the hydrostatic pressure. Blood is contained within the blood vessels, so it's going to be exerting a certain type of pressure on the blood vessels, which we call as a hydrostatic pressure. It tends to push fluid out of the vascular space, out of the blood vessels. There is an opposing force or an opposing pressure which tends to pull fluid into the vascular space. You refer to this opposing pressure as oncotic pressure, which is offered by proteins, or you can call it as an osmotic pressure, which is offered by electrolyzed proteins and so on and so forth. There is a special type of oncotic pressure, or rather osmotic pressure, which is known as oncotic pressure or colloidal pressure that is offered by proteins. So it means that if this oncotic pressure is less, there'll be less blood that is being pulled back into the vascular space. So there is a balance between the osmotic pressures, which tend to pull fluid back into the vascular space, and hydrostatic pressure, which tends to push fluid out of the vascular space. We call this as the Starling forces. Now, in an individual who has problems with the left side of their heart, they have some problems in filling of the heart, draining of blood back into the left side of the heart from the lungs. This blood is going to backflow to the lungs, and the pressures now, the hydrostatic pressures in the pulmonary vasculature are now going to be increased. Once these hydrostatic blood pressures are increased in the pulmonary vasculature, this is going to lead to fluid leaking out, being trapped in the interstitium, being trapped in the alveoli, therefore resulting in cardiogenic type of pulmonary edema. So this can actually be seen with both left ventricular as well as the systolic as well as the diastolic dysfunction. Now, what are some of the causes of cardiogenic edema? Anything that could result in a problem in a failure of the heart to pump or to work as a pump. It could be things like acute coronary ischemia, which is the most common cause. Over half of the cases worldwide are going to be due to this. It could be due to decompensation of someone who has a significant type of heart failure, even those that have heart failure with preserved ejection fraction that is due to hypertension. It could be in the background of patients with myocarditis, cardiomyopathies, valvular diseases, especially with aortic and mitral regurgitation, as well as stenosis for those that have moderate to severe disease. And it could also be with arrhythmias like atrial fibrillation, with a rapid ventricular response, ventricular tachycardia, even high degree and third degree heart blocks. All these could result in cardiogenic edema. And we shall be able to tell now the difference on X-ray, what is going to be suggestive of cardiogenic edema, what is going to be suggestive of non-cardiogenic edema. Now, in terms of cardiogenic edema, non-cardiogenic edema, remember that the heart is not really the problem in this case. So it means that there is some sort of injury that is happening, and this injury that is happening is causing damage to the pulmonary vasculature, therefore affecting the permeability and increasing the movement of fluids out of the vascular space, increasing the movement of proteins leaking out of the vascular space. And remember, these proteins that are leaking out from the vascular space also have some sort of oncotic pressure. They have some sort of osmotic pressure. So they'll pull fluid into this extravascular space, and this results in accumulation of this in the alveoli as well as in the interstitial compartments. Often there is some sort of acute lung injury that's going to be associated with severe hypoxemia. When these two are present, we refer to that as acute respiratory distress syndrome. Some causes of non-cardiogenic edema may include things like pneumonia, inhalational injury, sepsis, acute pancreatitis, severe trauma with shock, multiple transfusions, and even judicious IV fluid use. Now, whatever the case that is happening, regardless of the cause, the effects that are going to be there, resulting in clinical features of pulmonary edema, are largely going to be the same. What's going to differ here is what is underlying, what is causing the pulmonary edema in the first place, but ultimately the effects are going to be the same. So generally, there's going to be an imbalance in certain of these Starling forces that we see across the blood vessels. There's going to be things that are going to be increasing the filtration of the fluid and the solute from the pulmonary vasculature. So it could be things that are increasing the hydrostatic pressure, like I already explained. This is because of this backflow, this retrograde backflow of blood back to the pulmonary vasculature, because the filling pressures on the left side of the heart are higher. Or it could be due to an increase in the interstitial hydrostatic pressure. The fluid in the extravascular space up is pressing on the blood vessels and squeezing more fluid out of the blood vessels. It could be due to endothelial injury or disruption of the epithelial barriers. It could be due to a decrease in oncotic pressure. Remember that the oncotic pressure is offered by those proteins that are found in the bloodstream. So things like albumin, things like fibrinogen. Albumin, very, very important. So patients that are losing proteins, maybe they are having a nephrotic syndrome, they have renal causes, or maybe they have some hepatic causes, maybe it's even malnutrition, could result in a decrease in oncotic pressure and potentially could result in pulmonary edema. It could also be lymphatic insufficiency, something that is blocking the lymphatics. Remember that the lymphatics are very important because they're going to be taking this fluid and pushing it back into the bloodstream from the interstitium. So if there's something that is blocking these lymphatics, potentially it could result in edema, or indeed increased negative interstitial pressure, which could generate this sucking-like pressure that draws more fluid from the vascular space. In terms of clinical features, what do we expect to see? So remember, this is a person who has their alveoli are filling with fluid. The interstitium is filling with fluid. Gaseous exchange is impaired. It's like they'll feel like they are drowning in their own lungs. So they'll have this extreme dyspnea, they'll have this restlessness, they'll have this anxiety, and this sense like as if they are suffocating. They may sometimes have a cough, with this blood-stained sputum, though frank hemoptysis is quite uncommon in pulmonary edema. In terms of the signs, they may have pallor, they may have cyanosis, they may have marked diaphoresis. These are very common signs. The pulse is going to be rapid and low volume. The BP can be variable. So they may have a significant high blood pressure. This is usually shows that they have some sort of significant cardiac reserve. Then they may be hypotensive, which is a very worrying sign, especially if their BPs are less than 100 millimeters of mercury systolic blood pressure. They may have inspiratory fine crackles. This is very, very important, especially the crackles. Very important because it can help you distinguish between cardiogenic versus non-cardiogenic. In cardiogenic type of edema, the crackles that you're going to be hearing are fine crackles. Whilst in non-cardiogenic edema, most likely they're going to be coarse crackles. You can call them crackles, rails, or crepitations. But generally, you hear them widespread anteriorly as well as posteriorly on all the lung fields. You'll have this marked wheezing, this cardiac asthma, especially in patients with cardiogenic edema. Then other features that may be suggestive of cardiogenic edema could be things like an S3 and an S4 heart sound, which could be merged together. They could have a gallop rhythm. This is very common in cardiogenic edema. They could also have features of right ventricular failure. They could have things like neck vein distension. They may have peripheral edema. All these are suggesting a cardiac etiology. Sometimes it's very difficult to actually even hear these cardiac sounds because of the noisy respiratory sounds that you're going to be hearing as this person is trying to breathe. Now remember that in both patients that have cardiogenic and non-cardiogenic edema, they will have progressive worsening dyspnea, they will have tachypnea, they will have crackles on examination, and they will have hypoxia. These are features that are common to both cardiogenic and non-cardiogenic. Whilst in those that have non-cardiogenic edema, they may have other additional signs that may point you towards a certain pathology. For example, if they have an infection, in terms of a pneumonia, they may have a fever, they may have a cough with expectoration, which is a productive cough. They may have dyspnea pointing you towards a pneumonia. Sometimes they may have this history of recent trauma, they may have blood transfusion history, they may have history of receiving IV fluid. Now, what you're going to hear on auscultation, like I told you, whether you're going to hear fine crackles or coarse crackles is very crucial because it will help you determine or have an idea whether this is cardiogenic versus non-cardiogenic. Of course, even on other modalities like investigative tests like an X-ray, you can actually judge and tell whether this is cardiogenic or non-cardiogenic. I do show you in this particular lecture. So if you hear fine crackles, like I said, this is highly suggestive of cardiogenic pulmonary edema. This is because when someone is inspiring, those alveoli which are very small that had closed abruptly open. So this opening of those very small alveoli that had closed is what results in these fine crackles. Sometimes they may have hypoxemia, which can be severe, and carbon dioxide retention, which is a late sign, and it's quite worrying because it may point you towards secondary hyperventilation. Now, what investigations do we aim to do? Some imaging, of course, chest x-ray, very common. Make sure that you get one, but do not send a patient for x-ray that is unstable. An ECG and an echo, lung ultrasound, pulmonary artery catheterization, transpulmonary thermodilution. You could have some other labs like serum BNP or NT-proBNP levels, troponin, blood urea nitrogenous products, creatinine, ABGs, as well as serum albumin. Now, in terms of a chest x-ray, this could help you pick out whether this is cardiogenic versus non-cardiogenic. It may also help you determine whether this person has edema in the first place. So some of the things that are going to be suggestive of pulmonary edema include things like curly B lines or even thickening of the interlobar septum. It could be cephalization. It could be increase in the cardiothoracic ratio. I'll show you what these things look like. It could be peribronchial cuffing. It could be thickening of the fissures. It could be increase in vascular markings, interstitial edema, even a bat's wings appearance or a bat's wings pattern. This is what curly B lines look like. So you're going to see these very fine lines that are extending from the periphery, about 1 to 2 centimeters extending from the periphery, going towards the hilum. They are parallel to each other, and of course they are at right angles to the pleura. So they are going to be because there is this distension of the interlobular septum, and generally we see them more frequently in the lower zones of the lungs, but you can see them elsewhere, even in other zones of the lungs, but they are very common in the lower zones of the lungs. These are curly B lines, highly suggestive of cardiogenic edema, by the way. Then cephalization is where you get this redistribution, because you know that normally, because of the effects of gravity, there's more blood that is flowing to the lower zones of the lungs than there is flowing to the upper zones of the lungs. But now, because of this congestions, there is this maldistribution of blood, and you see that there is more blood now going to the upper zones of the lungs. And often we see this when there is pulmonary venous pressure that is exceeding 10 to 12 millimeters of mercury. That's when we get to see cephalization. Also a feature that is quite similar, or that's common in cardiogenic type of edema. Then another feature that is common in cardiogenic type of edema is your cardiothoracic ratio, which is just simply the size of the heart in relation to the thoracic cavity. So you measure the maximum width of the heart and you divide that by the maximum width of the thorax. So if you get a value that is greater than 0.5, greater than 50%, it means that there is some sort of enlargement of the heart. It means that there is some sort of cardiogenic type of pulmonary edema that is suspected. Then you may sometimes also see peribronchial cuffing. Now, this here you have to be quite vigilant to actually pick it up, because it's a very salient feature, and sometimes if you're looking at it very quickly, you may miss it out. So remember that you have those small airways inside the respiratory system. So sometimes these small airways could be surrounded by fluid. Fluid builds around and builds up in these small airways, and such that when you look at it on the X-ray, you're going to see like the bronchus actually appears much more prominent, and you have a thin wall and you have this area of thickening around. It actually looks like a donut. It actually gives you an appearance of the donut. As you can see here, this peribronchial cuffing that you can notice in this area, you have another one also in this area here. Okay, so once you see this peribronchial cuffing, it's also quite suggestive that there is some sort of edema, pulmonary edema. This is what a bat's wings pattern looks like, or you can call it a butterfly pattern. I like to call it angel wing pattern. So you have this opacities that are more prominent at the hilum, and as they extend to the periphery, they spare the periphery. So you have this sparing out the periphery out there, and you have this common in the hilum. So classically, this is used actually when we're describing a frontal chest radiograph. Now, what's the now going to be the differentiating factors between cardiogenic versus non-cardiogenic edema? So if we look at the heart size, cardiogenic, usually the heart may be normal or it may be greater than normal. Non-cardiogenic, usually the heart is normal in size. When you look at those septal lines, the curly B lines, they're usually present in cardiogenic edema, not present in non-cardiogenic edema. Air bronchograms are quite present in non-cardiogenic edema. They are not present in cardiogenic edema. Peribronchial cuffing is quite common in cardiogenic edema, is not present in non-cardiogenic edema. The pleural effusions are quite common in cardiogenic edema, not common in non-cardiogenic edema. Then, of course, distribution of the edema is usually central in cardiogenic and patchy and peripheral in non-cardiogenic. And vascular distribution is usually balanced or inverted, where you have the cephalization. In terms of cardiogenic edema, it's usually normal or balanced in non-cardiogenic edema. That's a way in which you can distinguish between the two. You may also need an ECG that may help you make a diagnosis of acute ischemia or myocardial infarction, and echo can sometimes help you in making a diagnosis of left ventricular systolic dysfunction, even valvular diseases. You may even combine it with tissue Doppler imaging if you want to actually look at the mitral annulus, and sometimes this can be done in the presence of the diastolic dysfunction, and you can assess this. Other imaging that you want to do for these particular patients, you may want to do a lung ultrasound. So this is supposed to be lung ultrasound. It's actually doesn't have any radiation exposure. It's non-invasive, so it's quite good for patients. And it can actually even help you detect the extravascular lung water before the clinical manifestations actually come out. You can also do pulmonary artery catheterization, which by many actually they do consider it as the gold standard in determining the etiology of pulmonary edema. So it's actually an invasive procedure. You're going to be monitoring the systemic vascular resistance, the cardiac output, the filling pressures, and if you get an elevation of the pulmonary occlusion pressure over 18 millimeters of mercury, then usually this is suggestive of a cardiogenic type of pulmonary edema. Lastly, you may do a transpulmonary thermodilution. It's also another invasive modality test, and this one is usually reserved for those that are undergoing cardiac surgery, those that are going vascular surgery, thoracic surgeries, even those that are in septic shock. This one can actually monitor certain indices like the cardiac index, the mixed venous oxygen saturation, the stroke volume index, and even the extravascular lung water that may be present. In terms of the labs, remember, want to do a serum brain natriuretic peptide or your N-terminal pro-BNP. These ones are usually elevated in pulmonary edema, and this is what is going to actually help you distinguish between an acute exacerbation of a COPD and a pulmonary edema. Often, the BNP levels are going to be normal in someone who has an acute exacerbation, whilst in patients that have the pulmonary edema, it tends to be elevated. Remember that this is an enzyme that is going to be secreted when your myocytes, especially those in the left ventricle, have been stretched out because there's increase in ventricular blood volume, there's increase in intracardiac pressures. So remember that elevation of the BNP is going to be correlating to the left ventricular end diastolic pressure as well as the pulmonary occlusion pressure. So this is often seen in patients with congestive heart failure. So if you get levels that are less than 100 picograms per mil, it's usually suggestive that heart failure is less likely. It's unlikely to be the cause. Then if the values are greater than 500, it's quite suggestive, highly suggestive that heart failure is the cause. Your only problem is that when you get values between 100 to 500, they are not going to help you so much in the diagnosis of heart failure, because in most critically ill patients, we tend to see them within this particular range. You also want to get your troponins that may be elevated, especially if you're suspecting an acute coronary syndrome. You want to also do your serum albumin. Remember that low levels of albumin, that's an albumin concentration less than 3.4 grams per deciliter, usually can be used as an independent marker of increased in-hospital and post-discharge mortality, especially for those patients that present with acute decompensated heart failure. But in isolation on its own, if you get low levels of albumin, it generally does not lead to pulmonary edema, because there is a concurrent drop in this pulmonary interstitial and plasma albumin levels that are going to prevent you creating this gradient over the pulmonary vasculature. Now, how do we manage these patients? So generally, we want to treat the underlying pathology and treat the underlying cause. If you do not address that, you're not going to do this patient justice. You want to alleviate the signs and symptoms. Respiratory support is very important. Use of diuretics, vasodilators, analgesia, and anxiolytics, and in some cases, inotropes may be used. In terms of respiratory support, remember that you could use both non-invasive, that's either the CPAP or the BiPAP. Often we do prefer BiPAP, and invasive type of ventilation. If the non-invasive fails, you may opt to actually intubate your patient and mechanically ventilate them. Remember, you want to have this positive airway pressure ventilation because you're forcing some of this fluid back into the vascular space. You're increasing the pressures in the alveoli and forcing the fluid back. So they may have a good effect on the patient. It may improve oxygenation. It may actually even push back the fluid, the alveoli and the interstitial fluid into the capillaries. It may improve any hypercapnia. It may reverse any respiratory acidosis. And lastly, it will improve tissue oxygenation. Very important that you should put your patient on some sort of respiratory support. And in some cases, it will also reduce the work of breathing. So whether you want to put your patient on a ventilator or not will depend on several things. Whether the patient is improving when you have given them the drugs. I will talk about the drugs very shortly. Their patient's mental state, those that are obtudated, those that have decreased level of consciousness, you want to intubate them. Overall energy of the patients, you don't want them to tire, or if they don't even have any energy. So in patients that you actually decide to mechanically ventilate, number one, make sure that your BPs are high, because remember, positive pressure ventilation will also drop your BPs. So continuously monitor your hemodynamics, because a reduction in the preload can result in a reduction in your cardiac output and therefore a reduction in the BPs. We often want to start off with non-invasive ventilation, so we can start off by giving them 100% oxygen via a non-rebreather mask, put them in an upright position. If this fails, you can progress and actually perform non-invasive positive airway pressure ventilation with your BiPAP or your CPAP, whatever you have. And if carbon dioxide retention is present or the patient is obtudated, then you want to intubate this patient and mechanically ventilate them. Diuretics are actually the mainstay of treatment, and they're commonly going to be used. We may actually use quite higher doses than usual, though these have been associated with some sort of worsening renal function. Generally, furosemide is the gold standard, 0.5 to 1 milligram per kg IV or continuous infusion of 5 to 10 milligrams per hour. So usually a dose between 40 to 100 milligrams of furosemide or even 1 to 2 milligrams of bumetanide can be used. Although patients that are already taking these, like those that are heart failure patients, may require higher doses of these diuretics. And how these diuretics actually work is that they're going to get rid of the fluid inside the vascular space. And once they get rid of this fluid inside the vascular space, it sort of creates a vacuum that draws back this fluid from the interstitium and from the alveoli, and therefore helping the edema. So it doesn't get rid of the fluid that has already left the vascular space. That's what you must understand. And in terms of vasodilators, these can be used as adjunct therapy for those that are taking diuretics. A drug that is commonly used is IV nitroglycerin, and this one often lowers the preload. It also lowers the pulmonary congestion. Remember that this should only be used in those patients that have a systolic blood pressure greater than 110. So generally, we can give your nitroglycerin 0.4 milligrams sublingual every 5 minutes. Then we can follow this by an IV drip at 10 to 20 micrograms per minute. So we can titrate upwards at 10 micrograms per minute every 5 minutes as we need, and with a maximum of 300 micrograms per minute if your systolic blood pressure is greater than 100 millimeters of mercury. So remember that the formulation, the infusions can come as 25 milligrams in 250 mils, 50 milligrams in 250 mils, 100 milligrams in 250 mils, and the injectable solution comes as a 1 milligram 5 milligrams per mil. So generally, we use a preparation where we add 50 milligrams to 250 mils of solution, either 5% dextrose or normal saline. So we usually start off at 5 micrograms per kg per minute. We increase by 5 micrograms per kg per minute every about 5 minutes, up to 20 micrograms per kg per minute. Then we can increase by 10 or 20 micrograms per minute if needed. But generally, we should not exceed a maximum dose of 300 micrograms per minute. Another drug that we could use is neseritide, which is a recombinant brain natriuretic peptide that also does have some vasodilatory properties. So it has been shown to actually reduce the pulmonary capillary wedge pressures, the filling pressures, and but though there is no subsequent improvement in the dyspnea that has been noted from research. There are other newer drugs like serelaxin, which is a recombinant form of the pregnancy hormone, which is known as relaxin. They also induced nitric oxide activation, which causes this vasodilatation. Clevidipine can also be used. It's an ultra-short-acting calcium channel blocker that can be initiated very early in presentation and has actually been shown to be associated with reduced hospital stay, improved dyspnea, and less frequent ICU admissions. You have also other drugs that could be used in other situations like nifedipine. This is only used for prophylaxis and treatment for those that have high altitude pulmonary edema. Remember, this is a calcium channel blocker. It will counteract the hypoxia mediated vasoconstriction that happens in the pulmonary vasculature. So it's also going to lead to lowering of the pulmonary arterial pressure with subsequent improvement in the gaseous exchange, exercise capability, and even the chest x-ray picture. Remember that nifedipine is only going to be used as a prophylactic strategy when altitude acclimatization cannot be achieved in those patients that are high-risk patients, including those that have rapid rate of ascent up the mountain or wherever, if they have extreme physical exertion, if they've recently had a respiratory tract infection, those that generally live at lower altitudes. Then you also want to give them an analgesia and anxiolytic, but here you have to weigh risk versus benefit. Morphine can actually be used, and it can actually reduce the systemic vascular resistance. It can actually act as analgesia. It can also act as an anxiolytic. So generally we use it, especially for those that have pulmonary edema that is because of acute coronary syndrome. But remember, it causes respiratory depression, so it may actually increase the need for your patient to be intubated, but generally we don't recommend it. If you do give it, you can give morphine 1 to 5 milligrams IV once or twice, and generally this has been shown to reduce the severe anxiety, it reduces the work of breathing, but it's actually has been associated with poor outcomes, so often we don't use it routinely. Sometimes we may consider using inotropes such as dobutamine and dopamine, especially for those that have a pulmonary congestion with associated low systolic blood pressures, because we don't want to keep giving them fluids, and those that have signs of tissue hypoperfusion. So in an event of adverse effects such as tachyarrhythmias, ischemia, and hypotension, we can use other drugs. Milrinone, which is an IV inotrope, has some vasodilatory properties, but it's also going to be associated with increased post-discharge mortality in patients. Now, lastly, you also want to treat the underlying cause. So remember that for those that are having this acute myocardial infarction or those with an acute coronary syndrome, thrombolysis or direct percutaneous coronary angioplasty with or without a stent can be done. For those that have severe hypertension, you want to give them an IV vasodilator. For those that have supraventricular or ventricular tachycardias, you want to directly perform direct current cardioversion. For those that have rapid atrial fibrillation, cardioversion is going to be preferred. So you may also slow the ventricular rate by giving them an IV beta blocker, IV digoxin, or even cautious use of an IV calcium channel blocker. And remember, in patients that do have an acute myocardial infarction, the fluid status before the onset of the pulmonary edema is usually normal in this patient. So diuretics are less helpful in this patients with acute decompensation of the chronic heart failure and may actually even precipitate hypotension in these patients. So if your systolic blood pressure is less than 100 millimeters of mercury, or if shock develops, then you can use inotropes like IV dobutamine, or an intra-aortic balloon pump. Counter pulsation may actually be used in these particular patients. I really hope you enjoyed this video on pulmonary edema. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.